Welcome to the Physician Leaders Network webinar on effective teamwork. This webinar is for you if you work with a team and if you've ever wondered how to increase your team's effectiveness. Your presenters today, I'm Michelle Hannay with the Alberta Medical Association, and joining me is Dr. Rick Ward. And you're involved in so much, I'll just let you give the description.
Yeah, so I think, thanks Michelle, in the context that we're speaking now, community-based family physician, and have had the privilege to work in an interdisciplinary primary care team for a couple of decades now.
Wow, that's quite a badge of honor. So these Physician Leaders Network webinars are provided, they've been designed by physicians for physicians and other health professionals, and in partnership with the Alberta Medical Association, Alberta Health Services, and the Alberta College of Family Physician. And the goal is that we'll provide free and easy to access tools and resources for physicians and teams to lead system transformation.
It's a noble goal, but one that we will surely finish off in this webinar. Yes. No, I'm thinking we'll be good now. So
okay, no pressure.
I have all the mistakes and all the pitfalls, so I can share those, and then we'll be good.
Okay, perfect. All right, before we begin, there's a summary handout that's available if you wanted to go to the website on the screen and just pause here and print that off. Then if you're someone who likes to take notes, a lot of what you'd like to write down is probably there, and then you can just add in your thoughts. And you may want to grab a hot beverage or a beverage of your choice. And
we didn't get one of those, but that's okay.
That's okay. Yeah. All right. As we get started, I want to start with a little sports trivia, since it is actually, we're recording this during March Madness, so it seems appropriate.
And just before the playoffs.
Exactly.
Sorry, Edmonton.
Well, in this case, we're talking about researchers at the University of Texas, and someone gave them a grant to study the question, can the abilities of individuals predict team success? And so they figured out a system where they applied a numerical score to each player, looking at professional baseball and professional basketball. And they thought, if we can add up those scores, will that be predictive of who wins the championships at the end of the season? So for one of the sports, they were able to predict with 90% accuracy, and for the other sport, only 35% accuracy. So what do you think? Which sport had the higher accuracy?
Geez, I'm thinking of weird sports, so throw me a bone.
Okay, all right. The answer is baseball was easy to predict using the skills of the individual. And why do you think that might be?
Yeah, because it's all about individual effort, really. I see where you're going with this. I like it.
Yeah, because really you can win a game based on batting, pitching, all of those individual aspects. And the teams don't really interact with each other much, right? They stay on their base and they run around. Whereas in basketball, you can be a really good shooter. But if your team can't get the ball up the court to the shooter, then it's not going to happen. And there's much more complexity because you've got the other team kind of, running interference, and they're much more unpredictable. So there's a higher level of complexity to the game as well.
And so maybe bringing it into healthcare, when we talk about interdisciplinary and multidisciplinary, I think of the baseball team as more multidisciplinary, where people are all sort of doing their own things and creating magic in their own world, whereas interdisciplinary is more like the basketball team, where you build off each other's strengths, you do those seamless handoffs, and you score the 3-pointers. So I like that.
Yeah, exactly. And the other connection to primary care is that I'm sure in your tenure as a family physician, you've noticed an increase in complexity, both in the patients that you're seeing, the conditions that you're expected to care for now that maybe would have been managed in specialty before, but now they're on your plate. And then also the system that you work in. So everything from the complexity of the EMR to the referral.
And patient expectations
Yeah.
too, right? We've got Dr. Google who's always in the
Yes.
room with us. So it's nice to have a smart pharmacist or nurse or behavioral health consultant that you can rely on for some extra support.
Absolutely. So you were talking about interdisciplinary teams, and you're absolutely right. That is the route that we need to go to manage the complexity now in primary care, and especially as we move towards a patient's medical home approach, that teamwork is going to be critical. So the Alberta Health, when they published the Primary Care Networks Review, they defined interdisciplinary as the integration of knowledge and expertise of several disciplines to develop solutions to complex problems in a flexible and open-minded way. And I think that really captures a lot of what we're getting at here, that if we're going to manage the complexity, we have to think of teams a little bit differently.
Yeah, Michelle, and I think the complexity is, part of it is clinical complexity, but the other part of it is the complexity that we're being asked to do in primary care. Gone are the days when it was just seeing sore throats and runny noses and writing our Amoxil 500 prescriptions. We're now asked to look at our populations, look at our panels, understand their needs, understand how we can provide continuity care and chronic disease management. And that sort of proactive planned care is a lot different than that responsive care. Somebody comes to the office and says, I have this problem, I'm going to solve it. So really the way primary care is evolving is it's evolving to a place where the only way to really solve those complex problems is through the use of an interdisciplinary team.
Absolutely. And it kind of makes sense then when you think back, and you were around when PCNs were first conceived of, and that was really where a lot of energy went with PCNs, was focusing on teams and team-based care. In fact, if you look at the key PCN program objectives for the very first ones, team-based care was one of those 5.
Yeah, and when we started on the PCN journey, they said function as teams, but they didn't really give us a playbook. And I remember early in my journey, a wise primary care leader by the name of Lorraine Buchholz looked at me at one stage and said, you know, Rick, team-based care is not you telling everybody what to do. It's all of us working together. And so I've certainly learned some hard lessons over the years about some of the ways to function better as a team. But this is where we started with those 5 objectives.
Yeah, you make an interesting point. Did you learn about working in a team in medical school?
Not so much. Yeah, not so much. I mean, I think we've all been brought up with thinking that working as a team is intuitive, but it really isn't. And I think, as you know, and as you teach, Michelle, working as a team is really a skill that needs developed, just like the other skills that we utilize.
Absolutely. So I'm not sure if you saw this recently, just last month, the CFPC PMH provincial report card was released, which was quite interesting. And so it's kind of, we know that in the 2013 vision for PCN evolution, where the whole concept of patient's medical home came out, and now we're getting report cards on it nationally. And as you can see here, Alberta's doing really well. We're kind of
job done.
Way. Yeah,
Should we?
yeah.
Sorry, no.
And it's interesting because this is a little misleading. You can see we've got the green square in teams, which means, really what that means is that the provincial government is supporting teams, is applying resourcing in that area, which is great. We've got the resourcing, we've got the support, but the question is, do we have effectiveness? Are we using those teams effectively?
Yeah, we call them teams and we resource them as teams, but could we be better teams? And I think your point's nice to see the green, but let's make it even stronger.
Yeah. And so I think clinics and PCNs now are getting used to doing some of the measurements related to PMH. Certainly they're measuring TNA and looking at their screening as part of ASAP. As well as now looking at patient experience surveys, some PCNs have actually started looking at team effectiveness and surveying. And so that is something that's coming, it's going to be a focus in the near future here.
Yeah, I was surprised by this data, Michelle. I mean, we are moving towards a quality improvement era where we're measuring and evaluating the good work that we feel that we're doing, and we're not doing that so much with teamwork, even though that's the engine that's driving so much of our care. So I think a good highlight of the fact that in the next few years, I think we'll be spending more time assessing the functioning of our team. We're not doing it on a widespread basis right now.
Yeah. Well, one step at a time. Well,
that's true. That's true. Rome wasn't built in a day.
It's true. So we did learn a little bit. We've got the Alberta Primary Care Research Fund, and we looked at how currently in Alberta primary care teams are operating. And what we found is that we're still in a model of working alone together. So still kind of a referral-based approach where the physician might refer a patient to someone on their team, and there isn't necessarily a lot of interaction that way. It's very separate.
Yeah, and I think the slide as well, the visual really matches what we're often doing now, and just like in Alberta, those silos are coming down in our small towns, and likewise they're happening. Same phenomenon is happening in our team-based care. So what does that look like? So it looks like two providers talking together informally, looking at patient needs, solving problems. It may involve my diabetes nurse saying, Mrs. Shmoo is really having trouble with her diabetes care, and I think it's because she's got some stresses at home. Let's bring in our BHC and maybe look at developing some strategies. And that kind of informal back and forth with the patient's needs at the center is really the operationalization of moving towards siloed care to team-based care.
Yeah, and just for those who may not know, a BHC is a behavioral health
consultant. Right? Thanks, Michelle. I got to watch the jargon.
No problem. So we were curious to know, what can we do to be sort of organized in our approach to supporting teams in being more effective. And so we looked to Eduardo Salas, and he's an organizational psychologist out of the US, and he's published close to 500 papers and books, very, very accomplished in this area. He's an organizational psychologist, but I think he could use a little Marie Kondo in his life.
Makes me feel at home looking at that.
But so he and his team have looked at all sorts of teams working in areas of complexity. So aviation, the military, and healthcare. And from that, they wanted to see if they could distill down what are those key components that are critical for a team to really be effective. So they came up with the 7 C's. So these are the core team elements that all happen to alliteratively start with the letter C, conveniently. So we're going to go through each of those. So the first one is about capability. And this is really looking at who's on the team. So it makes sense. Do we have the right people as far as their knowledge and skills clinically, but do they have good attitudes about being part of a team? Are they really, do they really believe that working together they can meet the needs of patients better?
Yeah, so I think this is a good one to start with, because what I found in working on our teams is the unknown treasures that often occur when you bring team members together. And let me give you an example from this last week. We've just got a new behavioral health consultant psychologist joining our team, and typically they have followed a problem-based, solution-focused model where patients present with a problem and the emphasis is on finding a solution, maybe bringing in a little CBT. Mm-hmm. Guess what? this BHC had expertise in DBT. So for our borderline patients, she will be a great resource that doesn't necessarily fit the problem-based model. So recognizing that the team that you come in with often have capabilities which are beyond their official scope of practice is a real find. So think of the strengths and the capabilities that team members bring in that go beyond or push to the limits of their scopes of practice.
Yeah. What about your HQCA panel report? What can that do?
Yeah, the HQCA panel. So this is a panel report that really tells us where we are in terms of looking at outcome measures. In fact, mine just came in today for my last quarter, and so this is a really good piece of information that can help identify gaps within your practice and ones that can be shared with team to be able to help focus activities. So a great tool.
Yeah, and so you may be thinking that you may feel like you're delivering babies all the time in your practice, and then when you look at it, you might find actually instead of a nurse who has low risk maternity experience, maybe your panel really needs a behavioral health consultant or somebody with a mental health background to really meet those needs, because sometimes what you feel isn't really what's reflected in the measurement.
Yeah, great comment. I work with several of the PCNs in my AHS leadership role, and the HQCA reports for one of our PCNs showed exactly that. It showed really a relatively small number of patients with diabetes and hypertension, but a large number of patients with mental health challenges. So what that PCN did is they revised their business plan and they revised their team members to reflect more emphasis on mental health. So understanding who your customers are or who your clients or who your patients are really helps you to build the kind of medical home that provides service to those patients.
Yeah, fantastic. And I would imagine that increasing skills and knowledge falls in here too. So you've got people with you for a while, and sending them for courses and bringing in people who can share knowledge is probably important too to meet those.
Yeah, and there's so many great opportunities right now for interdisciplinary education. And I guess what I would say is another key success factor in helping teams work together is learning together. So there's nothing more powerful than having a speaker on diabetes come in and talk about their latest therapies when you're sitting next to your diabetes educator, you're sitting across from your health management nurse, and you're sitting next to your partner when you're really looking at providing the optimal care for patients. And the sort of magic that happens when you talk about the challenges and talk about how to integrate new concepts into patient management really is energizing and results in better care for patients.
Yeah, that's good. You're speaking the same language. Yeah. All right, let's move on to cooperation. So this one brings up a topic that comes up in quite a few of the C's. Teams that are able to cooperate with each other have to have psychological safety. And psychological safety is defined as basically, if someone has psychological safety, then they can come up to you and say, I have a question about this, I have a concern about something, I don't actually agree with how we're doing this, and they don't need to be afraid that they're going to be reprimanded or punished or even ridiculed for speaking up in some way. And so cooperation really is around those beliefs and feelings that a team has, and it's probably one of the most critical ones, because if a team doesn't trust each other, you're not going to see a lot of high functioning. And I know you probably have a few thoughts on this area.
Yeah. So I think trust is really the glue that holds a team together. So the question is, how do you create trust? And I think that for me, the thing that creates trust the greatest is when you sit down with a group of professionals, with your team members, and dream about how to provide better patient care. If you sit down together to look at mutual problems and then come up with solutions, all of a sudden you're on the same team. You're moving towards the same end of the basketball court, whatever, trying to bring that analogy back. But so working together to improve patient care, I find is something that really increases the trust between teams.
Yeah.
I'll just do another shout out really to the docs, because I think we really do set that tone. And in the good old days when Dr. Rick was telling everybody what to do, it may have felt good for my ego, but it really didn't promote trust. And so the ability for me to ask questions, the ability for me to, for the love of goodness, listen to the great input that my team members had, the mutual respect that creates, it really does increase that trust account. And as you said, Michelle, that psychological safety, the saying that it is okay for me not to know. One quick story, one of the golden moments that I felt we had in our team is the doctors were at a CME on diabetes, and the rhetorical question was, so what medication should you add to a patient with type 2 diabetes whose A1Cs aren't a target after you initiate metformin? And there was silence in the group, and one of my younger colleagues bravely said, well, I add what Amy, the pharmacist, tells me to add. And there was no ego, there was honesty. We all laughed because we recognize that our team members actually make great decisions and have great information that we may not have. So that's the kind of cooperation and trust that I think drives a high-functioning team.
Absolutely. And it also speaks to psychological safety is important for safety in healthcare in general. And I know, I think it was in a Malcolm Gladwell book or something, they were talking about the Asian Airlines crashes when, because of the hierarchy, the co-pilot didn't have the psychological safety to tell the pilot that they were concerned about a problem, and they crashed. And I think too, my mom back in the 1960s was a nurse in the OR, and she told me one time she watched the anesthesiologist intubate the patient, and he forgot to check to make sure it was in the right place. And so she tried to suggest, like to just, to kind of step in, like, did you want to check that? And she was soundly put in her place that she would lose her job basically if she questioned. And the patient died because they were not intubated properly. And so she did not have psychological safety to speak up on the patient's behalf when she felt that something wasn't right. So that's something in healthcare in general that is definitely changing. That's a sad example, but certainly physicians of my era could sort of totally see that happening. And for the docs that are saying what is psychological safety, I mean, we create that psychological safety when we're in the room with our patients. It's that unconditional listening, it's that unconditional caring, it's putting that relationship at the forefront, and being accepting of whatever comes from that patient. So it's really a question of transferring those skills to working as a team. Yeah. All right. Oh, and collective efficacy again is just that that the team believes that they're stronger as a group, that collectively they have more impact than working alone.
Yeah.
All right. Coordination is the next one. And this speaks a lot to communication, and in primary care we really promote structured communication. So for instance, huddles, and I'm not sure, do you do huddles in your clinic?
I huddled this morning. In fact, I did a bit of a rant as well as the huddle, but we won't talk about the rant part. But yeah, huddles, so especially when our emphasis is on access, what we found is that by sitting down and spending 5 minutes proactively looking at the next couple of days, that we could often identify 2 or 3 patient visits that could be best served other than through a doctor's appointment. So what might that look like? Mrs. Schmoo is coming in to get her blood pressure checked. Well, Esmond, our super pharmacist, is got space. Not only can he help assess Mrs. Schmoo's blood pressure, he can also talk to her about lifestyle and do a whole bunch of things that in the context of a 10-minute visit I couldn't do. Right. That 10 minutes frees me up for the patient who calls who needs to be seen with a timely illness. So the pushback on all these coordinations is we don't have the time. But what we really have found in our practices is that by taking the time to meet and coordinate makes us more efficient, reduces the stress of the day, and guess what? Increases the cooperation and the sense of team and the trust that we talked about in the previous slide.
Yeah, absolutely. Do you do debriefs? So let's say at the end of the day, if there's been perhaps an incident, do you meet? Yeah,
I think we're not as good, Michelle, at that. I mean, we tend to have our debriefs around critical incidents. So when there has been a patient outcome that has been less than positive, then we'll have a formal structured debrief. And it's beyond the context of this podcast, but really we go into this saying there is no blame. How can we work together to do things better? Nobody feels good that Mrs. Schmoo didn't. Mrs. Schmoo is very complicated.
Yes.
Anyway, that she didn't learn about her time-sensitive test until 3 days after we got the results. How can we improve things? So it's an important part of those critical incidents, but I take your point that sitting down at the end of a crazy day to sort of say as a group, hey, that was a day, how might we have done it better? Here's why it was difficult.
Yeah, absolutely. And actually I had a physician the other day talking about this, saying, hey, why do we reserve debriefs just for negative things? How about if we have a great day? We just pull the team together for 2 minutes at the end and say,
high fives, group hug,
exactly.
TGIF. Whoops, no, sorry, we can't. It's credited. We can't talk about that. Yes.
Not yet. And then of course our EMRs, as much as they can be a source of frustration for teams, they can also be a great source for coordination and communication. So do you use the EMR messaging on yours?
So that would be like my rant from this morning. So okay, so full disclosure, I am not the EMR chairperson. But I will say that there is no question that the coordination within the clinic and the efficiency is way improved by using an EMR. And by having EMR champions, a shout out to Janet, my partner, who in the office, who pulls my knowledge up in this area. So definitely it's a way of, in a timely fashion, coordinating care, coordinating communication.
And of course, all of those activities lead to planning and self-correction, just like you were describing. And a good team also engages in backup behaviors. So perhaps your nurse is walking down the hallway, sees that an exam room hasn't been turned over yet, cleaned up, and notices that the MOA is chatting with a patient caught up in a conversation. Maybe this is going to put someone behind, so they just go in and clean up the room, just because they can see this is going to help the day go smoother if it's not my job, but I'm going to do it anyway.
Yeah, and especially around critical results, again, I'm thinking of Nurse AJ, who, when monitors incoming urgent results, and will print them off and put them on my pod with her bright colored red stat result. And will often come back to me through the day and say, did you get to Mrs. Schmoo's report?
Yeah.
Is there any action I need to take? So just like in safe air travel, redundancy decreases patient errors and negative outcomes. Redundancy and those backup plans and mutual monitoring, which is part of coordination, makes for a highly effective team.
Absolutely. All right. Communication. And of course, this has come into play already as we've been talking about cooperation and coordination. It's kind of hard to extricate it, but it's so important that I think it stands alone as its own C as well. And this is really talking about those things like interpersonal skills. So, if you're going to have a team that works well together, they need to get along, and they need to have the right attitudes and behaviors. And again, we see psychological safety popping up here in communication. Why do you think that is?
Well, you're only going to talk when you feel safe, and you're only going to be heard when the person on the other side is respectful and creates that safe environment.
Yeah.
And I think there's that pithy line about communication. I know you think you've heard what I've said, but I don't think you've heard what I really meant to say, or something like that. So there's that delivery of message, receiving of message, and then confirming of message. And one of the programs that Michelle and I attended really talked about the callback. And you see this in air traffic all the time, where the air traffic controller will give the instruction to the pilot, turn right on heading 451, and then the response back goes, copy that, turning right on 451. And so in the clinical environment, AJ, can you label this specimen as a punch biopsy mid-back? AJ says, right, so that's a punch biopsy, and that was done in the mid-back. Correct. So little tricks like that, because in the heat of the moment, in a busy office, I know my communication skills are not great, and so my team will compensate by doing that shout back to ensure that there's clear communication.
Yeah, those are great points. It reminded me actually of Google. A few years ago did a massive 4-year study, and so Google is comprised of multiple smaller teams, and they wanted to see, is there some critical factor or factors that make the difference between their very highly functioning, effective teams and the ones that were not performing as well. And the number one factor that emerged was psychological safety.
Wow.
So in those teams where they felt safe to talk to each other and share and question each other and could have healthy conflict and that sort of thing, they were really effective in producing the most.
Yeah, I don't think we can say that enough, and I'm going to stress that for us docs, I think we're the linchpin in this. I think we're so often responsible for creating the environment within our team. Remember that even though you may not have team leader written on your badge, your team will see you as being a leader and setting the tone. So if you're having a bad day, the team is not going to have a good day.
That's true.
And if you're not feeling safe, or you're not creating safety on your team or contributing to it, then it's really going to stifle that good communication and fun, for the love of goodness. Fun is an important part. That's an F. I don't think we do that on this. Anyway.
We'll find a way to make it a C. All right, the next one is cognition. So the team has a shared understanding. So I think we definitely see this on high-functioning teams where, you've made mention of AJ, your pharmacist. You know exactly the skill set that he brings, and you know exactly how he's going to do something if you send a patient to him. So there's that understanding of each other, and also the goals of the team. So that alignment toward the same vision or goals. And then there's the mental model, and this is another thing we learned when we did that research. The high-functioning teams, when you talk to them, they'll say, we take care of our patients, not, I take care of my patients and my team helps.
Mm-hmm. Yeah. Yeah, no, primary care is a team sport. When I think of this slide, I think of sort of two areas which are different but important. One is scope of practice. So what can professionals do? And back in the old days, I used to think, well, that was my job. I can tell everybody what's in their scope of practice. But, all of our professionals, the pharmacists, the nurses, the behavioral health consultants, psychologists, they all have their defined scopes of practice, which their regulatory bodies defined. So they are responsible for things happening within their scope of practice. The second concept is competence. So although it may be within my scope of practice to do a vasectomy, I am so not competent at doing that
Good to know.
yeah, good to know. I know you were not thinking about that. So competence is different than scope of practice. So when we're thinking about the tasks that need to be done within a team, we're looking at, so where does that task fit within the scope of practice and who's competent to do it? So if I look at diabetes management, we've got nutritionists, we've got certified diabetes educators, we've got health management nurses, we've got physicians. So all of us, it is within our scope of practice to give routine nutritional advice. But who is best at it? Well, Salima, our dietitian, but we want to keep her for the really complex patients. We know that our health management nurse, Lori, knows lots about nutrition and lifestyle, and it fits within her scope of practice. So we have her giving that kind of dietary advice to our newly diagnosed type 2 diabetics, even though all members of the team could give it. So there are sort of three different concepts, or two different concepts when you're thinking of what the role in the team is. What's within the scope of practice, and then who's competent at it. So just a couple of other concepts to go with the cognition C.
Absolutely. And then the third point we have on there is team norms. And it's interesting, every team has norms, whether or not they're aware of them or not. You bring people together for long enough, they're going to naturally create norms. I guess in effective teams, the difference is that they have consciously thought about what are our norms and what do we want our norms to be, and how are we going to make sure that new people are aware of what our norms are.
Yes, and for a different time and a different location, there's actually some very cool team norm exercises that you can do. I would also add that those kinds of cooperative team building activities build trust, increase communication, and conserve a function. And developing team norms is really one of those things that high-functioning teams will have articulated explicitly rather than implicitly.
And I think of one norm that kind of comes to mind is there are some clinics where when they're out in the clinic around patients, the team refers to the physician as Dr. Ward. But when they're meeting and as a team talking about how their what their vision is or doing their huddle in the morning, then you're Rick. And because we want to make sure that hierarchy doesn't get in the way of people feeling comfortable and having psychological safety around sharing what they think, what they believe. So any norms in your clinic around that?
Yeah, I'm laughing to say, yeah, the norm in our clinic is that the staff can't complain to me about being behind on my tasks in front of the patients. But no, I think that most of the norms that we've created in the past, and we've fallen off it a little bit, but were norms around how we communicate around conflict, and things like crosstalk and sort of complaining about others' standards of care, and really trying to move that into a more open environment. So those have been ours. And is conflict one of the C's?
It was. Eduardo Salas has changed the C's.
He's taken the
times.
Conflict.
He's embedded the conflict within communication and
right.
more. But it was a standalone C before.
So it's the silent C then. It's the silent C.
Yes.
So I would say that would be where our team norms have been helpful in dealing with.
Great. All right. You've alluded to this a little bit already. And it's around coaching, and in particular team leaders and how they set the direction. We talked a little bit about how physicians, even though they may not perceive themselves as leaders, others typically perceive them as a leader. But in the clinic, I've definitely been in a clinic where, the physician was a leader and perhaps the clinic manager was a leader. But there was an MOA who had been there since the clinic opened 20 years ago, and if she was not on board, nothing was happening, and everyone kind of looked to her for how they were going to feel about something. So it's really important to think about who are our leaders, formal and informal, and how are they coaching the team? How are they modeling the behavior that they want to see from the team? And so I know you've talked a little bit about that, but did you have anything else to add?
Yeah, and I think it's really just there being alignment between the formal leader and the informal leader. That to me is one of the key things. The distributed leadership point at the bottom of this. Distributed leadership works best in teams that are high functioning, where there's a lot of trust. The highest functioning teams have the flattest hierarchy, the team meetings where you walk in, where things seem to be getting done and decisions made, and yet you can't really tell who's leading the meeting. Those are the situations where you know you have a high functioning team.
Yep, that sounds about right, I think. All right, we're getting down. I think this is the last C. And this is about conditions. So do we have a supportive atmosphere? And I think that's both physical and non-physical. So really how the clinic is set up can either support or not support the effectiveness of a team. Any thoughts on that from how your clinic is set up?
Yeah, so I think the supportive atmosphere can't be underestimated, and that certainly happens on the day. Because we are in the whirlwind, right? I mean, patient calls, where's my referral? I need this refill now. Can we squeeze an extra patient in? So there's that whirlwind, and it's easy to get grumpy, and grumpy, negative, complaining physicians create an atmosphere that is infectious in a bad way for the team. So I think be aware that that the day-to-day conditions will often be set by the mood of the physician. And you can say, well, in a flat structure that shouldn't be the case, but it is. It really is. So be aware in the day of how your behavior is going to affect a team. Beyond that, we spend lots of time at our home clinic in ensuring that there are opportunities for all of us to interact in a formal and semi-formal manner. So we have yearly retreats where we take our staff, outside of the clinic to a nice location, have a lot of team building activities aimed at improving patient care, and also just having time to talk and to get to know each other. Those yearly retreats that we have with our staff pay off in gold in terms of the improvements of efficiency, the mutual support that we get out of them, and the fun that happens from them. It's really very energizing. So being very purposeful about creating conditions within the clinic that promote collegiality, psychological safety, is really part of what makes effective teamwork happen in healthcare.
Yeah, and I wonder about turnover rates.
Yeah, so I mean, really true. Your staff are gold, and when you think of the amount of time and energy that we spend in training staff, in bringing them up to speed and having them go through all of the protocols for security and privacy, how creating those team members improves flow, that to lose staff members is a huge impact on team. And the best way to keep those staff members is to create a team environment where people feel respected, they feel that they're doing good work, and they are doing important work. I mean, the work that we do in looking after patients is amongst the most satisfying work that people can do. And docs, we get that thanks every day from our patients, almost every patient encounter. But we know that the people who are at the front end make us do the magic that happens in the exam rooms. How many times will I have a patient will say to me, "Oh, Dr. Rick, thank you so much for squeezing me in today. I really appreciate it. I know how busy you are." And I look at them and I say, "I just go in the rooms. You got to thank Susie, who's just outside this door, who came to me and said, 'Rick, I'm squeezing Mrs. Schmoo in because you forgot all this stuff about her.'" No. So really recognizing that we get all the bouquets, and so much of the heavy lifting comes from our team members, and to share that love, I think, is part of creating good conditions.
Yeah, that's great. The last point here is that leadership sends signals that teamwork matters, and I think you touched on that. When leaders take the team away, when leaders thank them for their input, all of those maybe more intangible things. Anything to add to that one?
No, I think just reinforcing that we're role models, and being consistent in your behavior with the behavior that you'd like to see your team pick up. So if you're respectful and caring to your patients, and you model that behavior to your staff will model that behavior to patients. So it's just that alignment and consistency.
Beautiful system. Yeah. All right. So just if you weren't convinced, there is ample evidence out there to say that working on your team development has a lot of benefits, including job satisfaction and morale, which probably increases that retention rate of team members. When people feel like they have better autonomy and they're communicating well, the team just functions well and feels good. The thing that surprised me a little bit was that there's improvements in quality of care and patient outcomes. So patients actually do better, and not surprisingly, they're more satisfied. So anything stand out here in this list to you?
Yeah, I just think as a physician who's in my fourth decade, that sounds really old, and I think back of how I practiced in the first third of my career in primary care, where I was running on that hamster wheel, and if I ran a little faster, I made a little bit more money, and so I kept running faster. And I compare how I was as a practitioner who was really a solo practitioner in an office with other practitioners to working in team-based care. It re-energizes, it rejuvenates, it increases my satisfaction, and energizes me for the next 40 years. Okay, maybe not 40, my banker would say that, but so I really think that effective teamwork produces great results, but you know what? It also increases the energy and the love that we have for the craft that we've trained for.
And that's really, we spend so much of our time at work. It's good to love what you do and the people that you work with.
Right on.
All right, so the good news is we are just putting the finishing touches on what we're calling optimizing teams and teamwork in Alberta. So those of us at the AMA have partnered with the University of Calgary, and we've used the 7 C's as the basis. We've actually worked with Eduardo Salas to create a team survey. So it's very short and simple, and it gives the team some input on where they're at in relation to each of the 7 C's. And then we're putting together some practical tools. So if they decided to work on coordination, for instance, we've got some practical tools that they can try out and work on. And we'll be adding to that continually, developing that set of tools as we go. And we have designed them to be improvement facilitator friendly. So a clinic could work on it on their own, but we know that things tend to be received better when there's an improvement facilitator who's working with the team. So those will be available at the TOP website, topalbertadoctors.org. They're not there yet, but they're coming very soon, and we'll have a link to it with where the webinar link is.
And just a quick comment on the use of external facilitators. One of the success factors when we were moving to an interdisciplinary team model was bringing in somebody externally who can focus in on the process that happens within teams. So if that's available to you, either through your PCN or through the AMA, U of C collaboration, it would be a real benefit in helping you move forward.
Yeah, absolutely. That's definitely what we see. And I just put this in here as an example of one of those tools. So we talked about huddles, and if you've never done a huddle before, this is one of those tools that you could use. It just gives you kind of a little checklist, and we've purposefully left it in Word format so that you can adapt it to fit whatever works for your team. And there's actually a little end of day huddle, which would be more of one of those critical incident debriefs that we talked about as well. So just an example. And last slide, I just wanted to cap it off. We did have a quote from a patient who was brought in to be part of the team. So that's another...
That's not Mrs. Schmoo, though.
That is
no, not Mrs. Schmoo, no.
That is not Mrs. Schmoo, but that's very tempting. Anyway, she was brought in to actually be part of the team. So they bring her in for their team meetings, and she gives her input on the patient perspective. And they've found this particular team, really, really helpful and surprising in many ways. And so the quote we got from her was, she said, "I've learned that the doctor is on the bottom of the pyramid and the patients are on the top. And in between is a team, and we all work for one goal, for the patient."
Wow, very cool.
Yeah, so thank you very much, Rick, for your time and all of your knowledge and expertise around teaming. And we look forward from hearing from you again on one of these webinars.
Michelle, thank you for leading us through the C's. Now it's time to go out there and just do it. Thanks for your attention.
Thank you.